session on ICD troubleshooting, and welcome all to this sixth of the webinars. The entire webinar series of cardiac devices, and we have two extremely knowledgeable fellows in guys in electrophysiology. They are leading the way of field of electrophysiology in Eastern India, and both are very humble and very hardworking. What I perceived them over the last few years, and they are always open and to discuss everything and come up with. Whenever I have told them to give some talks and everything, they are always there. So without wasting time, the moderator of today's session is Dr. Rana Rathor Roy, and I invite him to take over the proceedings and invite the speakers. Rana, over to you.
Sir, I think Dr. Rana is not connected through audio.
Okay, so
Dr. Rana is to unmute, I think.
No, he is not connected.
Audio is not connected, right?
He's not connected through audio.
Yes, yes.
Yeah.
That option is coming initially. He has not chosen.
Okay, so let me do his work. Then he will be joining in between. So first speaker will be Dr. Debabrata Bera, and he's at Rabindranath Tagore International Institute of Cardiac Sciences, and he will be speaking on ICD troubleshooting. And over to Debu.
Dilip, I think Suchit, we planned as per the speaker. Suchit is the first speaker. Then I'll take over. Okay.
Yeah, to use.
Okay. Yeah. Okay.
Suchit,
Okay, no problem. Anyone can
planned
start.
in that way so that it remains understandable. The initial part will be discussed by Suchita. Then I'll take over. Okay, Dada. Thank you.
For the,
Okay, so I have to share it. So I have to give it right of sharing.
Souvik,
Okay.
Souvik, do the needful.
Dr. Suchit, you can share.
Okay.
Yeah, you can share, right?
Good. So about ICD troubleshooting, some case-based presentation. Cases are always real-world based, so definitely it is definitely a real-world cases. And based on these cases, I just want to discuss some points. It is not possible to discuss the whole things of ICD troubleshooting. Some part will be discussed by me. The other parts will be discussed by Debabrata. So we have to know first, whenever we are seeing an ICD troubleshooting, for an ICD troubleshooting, when we see our programmer, where we get all the data, there we see these four things here. We get a near field. If it is a dual chamber ICD, we get a near field for both atrium and the ventricle. If it is a single chamber ICD, we get the near field for the ventricle. And apart from the atrium and ventricle, we get something called as a leadless ECG. This is between the ECG, between the proximal coil and ICD can, almost like a lead one. And then there is a far field ECG, which is between the ICD can and the RV coil. And this is mostly used for a morphology analysis, where to differentiate between VT and SVT by morphology matching and accordingly deciding of the therapies by the ICD. And another thing what we see is a marker channel. So in the marker channel is in a short what the pacemaker or what the ICD makes out of the tracings. So we can always discuss a lot of things based on the far field, near field. We can apply our mind and all these things. But what is the mind of the ICD? The mind of the ICD is the marker channel, where we get the things which the ICD sees and how it acts accordingly. So that is the marker channel. Now this is a, now coming to that, now coming to why ICD patients will come to you. After implantation, there is a follow-up protocol, and also maybe by remote monitoring you want to follow up in these COVID days. So after this, why a patient will land to you, why he will come to the doctor. The most important reason, apart from the usual checkup, a patient comes to the doctor is after he has received a shock. So, so after a shock, and that should be also, whenever a patient has a shock, he should revert to the doctor to see why he has a shock. It is always thought that ICD is supposed to give shock. Yes, it is supposed to give shock as to prevent a sudden cardiac death, but it is always preferable for us to prevent a shock. And for that, we have to know why the shock has occurred and to prevent future shocks. We don't want to give pain to the patient. Another possibility when an ICD patient will land up to a doctor is that when he presents with an electrical storm. So if the patient presents an electrical storm, means if you have 3 or more episodes of VT-VF in a single day, that is defined as an electrical storm. And when a patient presents with an electrical storm, recurrent shocks, he will land up to you. Either he may need an external cardioversion if the ICD battery is over, or he may have some battery charge left before he lands up to you. The patient can also present with palpitations and syncope. If a patient is dependent on ICD, for pacing requirement, then you can, the patient can present with syncope also if there is some problem with sensing of the ICD. Even after having an ICD, patient can have a sudden cardiac arrest where the ICD may remain a mute spectator. There are reasons for that. And in those cases, the patient can come where emergency service team may have shocked the patient outside and brought the patient to you, or the patient can come with a sudden cardiac arrest resuscitated in the ER. And obviously nowadays the remote monitoring is there, so we can assess the patients when you have an alert on remote monitoring. So these are the ways when an ICD patient can land up to a doctor, and accordingly we have to act. Now, what is the analysis of ICD shocks? ICD shocks are analyzed based on the stored data and also the clinical data. These both are very important. And if you have a definite tachyarrhythmia associated with the shock, then it can be either a SVT or a VT or VF. We don't want to give a shock in SVT. Why? Because it is not required. We can control up with drugs, we can control up with ablations, we can do a lot of things. So, and also SVT mostly are hemodynamically tolerated, and we don't want to give a shock. So that shock is called as an inappropriate shock, means we don't want. Another is a VT or VF where you have an appropriate shock. So these are the tachyarrhythmia associated shock. Now, whenever you are seeing a ICD shock EGMs, you are seeing that there is no tachyarrhythmia as such, but the patient has shock. How can it be? So you see the marker channel. If you see the marker channel is showing that the ICD is thinking the patient has a tachyarrhythmia, but in reality, the patient doesn't have a tachyarrhythmia. Those things that ICD oversensing comes in this regard. So what can be oversensed? It can be an intracardiac signal or an extracardiac signal. I'm coming to detail later on. If the VT-VF appropriate shock is there, then the next thing you should keep in mind, was the shock preventable? We don't want to shock. Again and again, we don't want to shock. If it is preventable, then we have to think whether we can program the ICD such that we can give more ATPs or something like that, and we can prevent a shock. Or if it's a shock was necessary, then it is okay. Now coming to, this is already I have discussed electrical storm. Electrical storm can be due to a monomorphic VT or a polymorphic VT. And we have to assess the electrolytes, ischemia, heart failure. We have to sedate with a general anesthesia, hemodynamic support, amiodarone, beta blockers. And if it is not working, we can, if it is a monomorphic VT, it is usually scar related. And then an electrophysiologist can do a radiofrequency ablation of the VT, noting the scar, and that will result in the control of the electrical storm. If it's a polymorphic VT or VF, after ruling out electrolytes and all channelopathies, if you have a PVC trigger, sometimes what happens, a PVC can trigger VF, there electrophysiologist can do a radiofrequency ablation of that PVC, resulting in a control of the ICD storm, electrical storm. If it is a polymorphic VT, we have also an option of reducing the sympathetic outflow by a stellate ganglion blockade. If it is Brugada syndrome or an early repolarization with an electrical storm, then we can treat with IV isoproterenol followed by continuation with quinidine. Now, management of frequent shock, if it is inappropriate SVT, I have already discussed what can be done for an SVT. Now coming to non-physiologic causes of shock, where it is inappropriate and we have some extracardiac signals or intracardiac signal, which is oversensed and cause a shock. So I will be focusing on those. Now whenever you see a ventricular oversensing in an ICD, we have to think at whether it is a cyclical oversensing or a non-cyclical oversensing. Means, is it associated with each cardiac cycle at a particular part of the cardiac cycle every time or not? If it is cyclical oversensing, most of the time the problem is in the intracardiac oversensing. If it is a non-cyclical oversensing, it can be due to an extracardiac signal or an intracardiac signal. Now, whenever you have a cyclical oversensing, you have to think that whether how many oversensed events are there in per cycle. If you have a one oversensed event per cycle, think it is most likely to be physiologic, because you can have a P wave, T wave, or an R wave double counting, P wave, T wave oversensing. It can also be non-physiologic, but whenever you have more than one oversensed event per cycle, it is usually non-physiologic and mostly related to lead failure. If it is non-cyclical, then it can be either an extracardiac, where it can be myopotentials, which are physiologic, or a non-physiologic can be a lead connector problem or a electromagnetic interference. And it can be intracardiac, where again lead failure comes. So basically what I have discussed, these are the noise of a source of a noise. Now coming to my first case, this was some discussion, a short discussion. Now coming to the first case, this patient had a shock after he used a hair dryer. So these are the EGMs. The upper one is a RV tip to RV ring, near field EGM. The second is a RV coil to can, and third is a marker channel. Okay. Now, do we have any interactive things in this discussion, or should I give the answer? DILIP,
You can ask, Ravi, can we use a poll here? You can,
if you means I can give the answer, or I can go for an interactive thing also.
No, we will attempt.
Yeah, lead fracture, correct. Yeah. So Manish has given the answer, lead fracture.
Okay, so you think it is a lead fracture. Okay, so I have given 4 options. So you are taking the option 3, that is the conductor fracture of the lead.
High potential oversensing.
Okay, so these are another person. I cannot see the names here because I am presenting. So another option was given as oversensing of RR intervals. Okay, so we'll come to what is it now. See, these are the 3 things where what we can have usually. It can have a myopotential, you can have a EMI, you can have a lead fracture. Now, out of this, if you see myopotentials are usually associated with some isometric exercise or a Valsalva maneuver or a cuff like that. And usually it is not seen in the shock EGM. It is seen in the other EGMs, but usually it is not seen in the shock EGM. It is related to the lead. For example, the first image, it is showing that there is a myopotential related to the RV EGM, but it is not seen in the atrial EGM and the shock EGM. And on the other hand, EMI will be seen in all the leads. It can be shock EGM, and all the leads in the heart will show EMI. Usually, that is called as a typical EMI. There is something called as an atypical EMI also. So third point is what he was telling, that it can be a lead related problem. Now, lead related problem usually will involve the lead which is affected, and usually it is not seen in the shock EGM. It is seen in the near field of the particular EGM. Okay, so there are certain features of lead related issues. So these are there are few features. Number one, it is usually intermittent. It is not seen most of the time. Sometimes it may be seen. Second, it is usually not cyclical. Usually not cyclical. It can be cyclical, but usually not cyclical. Third, usually associated with sometimes a very short RR interval. Maybe here 120, 180, 170. These are not physiologic RR interval. Then you see that this must be something related to the lead. 4, there is no signal on the shock channel, and 5, it is a variable amplitude, morphology, and frequency, and 6, there is an amplifier saturation. So if we see our EGMs, here we have all the properties. I'll just mark it. So it is a high frequency signal. It is intermittent, means this part it is not there. It is irregular and it has saturation. So this is saturation. So if you have all these things, definitely you think that the patient has a conductor fracture, and correctly said so. So conductor coil fractures, mostly sporadic, can be without any detectable change of impedance and threshold. Here we see the curve below. You can see that the pacing, impedance, and threshold, everything is normal. Every time you are interrogating, you are getting a normal value. So that is some background where you can get a conductor coil fracture. And usually they present with oversensing and shocks. So these are the different, I have already discussed all these things. So myopotentials, EMI, lead fracture, and seal plug damage. I'm not going to detail. So the next case I am coming to, this is a post-CRTD. Patient had a syncope while swimming in a swimming pool. So we have the EGMs here, and also we have the marker channels here. So these are the options. So anyone wants to try? Okay. So we see here, when we see the EGMs, we see that the RV pacing is inhibited for a significant point of time. So you can see here, there is some noise detection, and for this the pacing has been inhibited. Now this will result in syncope. Now why it has been inhibited? You see there is this sort of high frequency signal in all the leads available. This lead, both are available, okay? So whenever you have signals in all the leads available, you have to think of EMI. And this is not a VF, it's an asystole because of oversensing. So it is an asystole due to EMI. And frequency of the EMI is also important. Here, if you see properly, you will see that the frequency will be between 50 or 60 hertz if it is there. It indicates an EMI from a alternating current source. So, and also you have this waxing and waning pattern, which is called as aliasing. So that also is a feature of an EMI. So EMI usually is in all leads, but if you have one lead not showing EMI, you have to think two things. One, it can be, sometimes very rarely it may not show. And secondly, it can be due to the autogain compensation, where that lead may have the values of autogain different from that of the other lead, so that it is not visible. If you magnify that, you can get. Now coming to case 3, this is a patient where we have this, this is a plot which is showing what is it showing basically. This you will get in the, this thing, your ICD interrogations. And you see these are the VV intervals in the chamber ICD. So you have two lines, one line at 600 millisecond, another line at maybe 300 millisecond we have. So what does this indicate? It has detected this as a VF and it has shocked. Anyone wants to try?
T-wave oversensing.
Okay, why do you think so?
There you have two lines in the ventricle chamber, so that's one is for the T and the one is for the R wave.
Correct.
This
so
railroad. This is railroad.
Yes, yes. So one interval will be larger, another interval will be shorter. No, alternatingly, the intervals will change based on the T-wave sensing. So here it is an example of T-wave oversensing. It's not from the same patient, but it has a dual chamber ICD. So there we can get the T-wave and the QRS is both sensed. But T-wave on oversensing is not, but this tram track is not usually definitely associated with T-wave oversensing. You have to remember there are differential diagnosis. You can have R-wave double counting where you have a loss of RV capture in a CRT. You can have an SVT to 3:2 Wenke back. There also you can have two lines. So these are the DDs. Also, you can have a cyclical noise due to lead fracture. There also you can have a T wave oversensing like of thing if the noise occurs at the time of the T wave. Management of T wave oversensing, you have to think the ratio between the R and T wave. If you have a big R waves and a small T waves, it is quite easy. There are different algorithms by different device companies by which you can adjust and prevent sensing the T waves, but sensing the R waves continues. If you have a small R waves and the normal T waves, it is very difficult to adjust this, and often lead revision is necessary. So these are different algorithms there. Different companies have different algorithms. Some algorithms may something called as a decay delay, sometimes called as a, some noise is there. Okay, so there are different ways by which you can control this T wave oversensing. Different companies, they can adjust the threshold start and the decay delay. You can, the threshold, they can start at 62.5% of the R wave, and you can put a delay there, which can start at 60 milliseconds. These are all programmable. By this, you can prevent T wave oversensing, but you can see a R wave. Even if the R wave height is low, there also you can see. So your idea is to prevent T wave oversensing, but at the same time, you should not miss a VT or VF. During VT or VF, the R wave height is supposed to be smaller than the normal sinus rhythm. Now coming to my fourth case, this is a patient with a HCM who has a history of cough-induced shock. Patient has an integrated bipolar lead in RV. So what is it? Can anyone tell? What is an integrated bipolar lead? Integrated bipolar lead is that where the coil is used as one of the electrodes of sensing. Another can be from the tip, and the tip to the coil is a antenna which senses the R waves. So that is seen with a particular make of a pacemaker mostly, and they have a wider antenna, so they are more susceptible to catch some external noises. So anyone can tell what is it basically, why there is a cough-induced shock?
Anuna has given answer of myopotentials.
Okay, great. So what myopotential? Is it a pectoral myopotential or a diaphragmatic myopotential? That is the next question. So let us go. So we have this is actually an RV lead, an integrated bipolar. So RV lead is nearer to your diaphragm basically. And if you see that the vector of this RV lead, the integrated bipolar antenna is very unlikely to catch pectoral myopotential. So usually RV lead myopotentials, if it is there, it is usually a diaphragmatic myopotential. Also, if you have a cough-induced shock, cough is actually associated with a diaphragmatic contraction suddenly. And so cough-induced or Valsalva-induced, if you have a myopotential oversensing, it is usually due to diaphragmatic myopotential oversensing. So you have to think whether it is a pectoral myopotential oversensing or a diaphragmatic. And I have already discussed it is more with an integrated lead than a committed bipolar lead. Integrated bipolar lead having a larger antenna. And we have to see oversensing is in which lead. Here the lead is RV. And what is to be done? So if you have, see, usually RV lead will have a diaphragmatic oversensing, also suggested by the cough. But if you somehow have a pectoral oversensing, pectoral myopotential oversensing in RV lead, which can rarely happen if there are certain conditions where it can rarely happen. I am coming to that. So this is the thing. So diaphragmatic myopotential. So if you have to switch to committed bipole. That is not wrongly written. It has to switch to committed bipole, because integrated bipole is more likely to have a diaphragmatic oversensing. And you have to see if you after doing the dedicated bipole also, you are having a diaphragmatic oversensing, then you have to think whether the lead position is correct, by whether it's a perforation is there or there is a middle cardiac vein placement. And if neither is there, you have to change the pace sense circuit. If it's a skeletal myopotential detected in the RV lead, now that is something which is not good, If a skeletal myopotential detected in the RV lead, it is unlikely to be detected because the local antenna is on the RV only. So there you have to think whether the patient has a DF1 or a DF4 lead. If it is a DF1 lead, sometimes what happens is that if you interchange your, usually pectoral myopotential oversensing is detected in the up this coil and this can. This is the axis of a pectoral muscle myopotential. Usually it will not be detected by here. So if you detect here the pectoral muscle myopotential, one of the possibilities is that you have switched, means you have connected the RV coil to connector to here, means RV connector you have connected to the port for superior vena cava coil, and the superior vena cava coil you have connected to the RV port. So what happens is that actually what is RV is actually an SVC coil, what it is there, and it is sensing the pectoral muscle myopotential. That is if you have a DF1 lead. But if you have a DF4 lead, that question doesn't arise because it is already designed, the lead is designed so that you don't have to connect both separately. So if you have that, then you think that there is some problem in the lead, means there is some insulation break or something from where you have a myopotential is catching, and it can be in the pocket also where that break is there, or anywhere up where it is in the course of the pectoral muscle. So if you have a DF4 lead, then there is no way but you have to change the whole lead, DF4. And if you have a fracture or something electrical insulation break in the pocket, then what happens is that your shocking vector comes from, see for example, you have a fracture here. The RV lead, so if you have a fracture here in the RV coil, so if you have a fracture here, then it comes very near to the pacemaker can, and this can result what is called as an arcing. Noise is coming. Okay. Okay. So whenever you have that thing, there is a possibility that you can have this something called as an injury in the can here. You can see that is because of the arcing, where the conductor which is going to the RV is coming by the side of the lead, and whenever you shock it, there is a short circuit between these two, and you have a plasma formation here, and you can have a damage to the can. So this is called as an arcing artifact. So this is something which is very ominous. I want to end by this case. This is a patient with ICD who was resuscitated with an external shock due to VF. So on interrogation, you see something white page on the left. Whenever you see this page, you have to be very, you have to understand that there is something grave problem here, because this is something called as a power on reset, or where the ICD goes into just a VVI status and high voltage therapy is disabled. Now, why it can happen? It can happen because of when interrogated this patient, we had a HV impedance of 35 ohms, R-wave sensing was 8 millivolt, and battery life was 5 years. So how is it possible that ICD didn't shock and you get a VVI reset and HV therapy is disabled? This can be explained by arcing, where you have a lead malfunction or lead fracture, lead insulation break near the can. You can have an arcing, and whenever you are having an arcing, you can have this reset of the VVI to the VVI, and high voltage therapy may be disabled. But you can question that how then the HV impedance is intact. HV, whenever you're checking the HV impedance through the device, usually it gives a low voltage, and it checks by that low voltage where it is conducting. Now, if you have these two are very nearby, if you have a low voltage, it can conduct from one to another. But if you have a high voltage, what happens is that then only this plasma formation occurs, and then only this reset occurs. So whenever this HV impedance, if it is normal also, it doesn't prove that the lead in this high voltage lead integrity is intact. So basically, whenever you have a very important thing is by checking the HV lead impedance, we cannot always tell. Those cases where you have a suspicion, you have to do a DFT testing to actually indicate the efficacy of the ICD. Thank you.
Thank you so much, Suchit. And Rana is there. Rana, the audio problem, the audio issue has been, taken care of. Rana. So, Suchit, great presentation and good cases. But I would like to, ask, show us the T-wave oversensing case. Can you go back to and share your
Okay. Which case?
T-wave oversensing? There was a gradual increase.
Okay.
Yes, you showed.
Yeah, I showed these are actually 1 second. This one you are seeing?
I can't see. You have not shared your screen.
Oh, sorry. Start broadcast.
Yeah, there is a gradual. You can appreciate here. There is a gradual increase in heart rate before the joules were given. You can appreciate from 100 to it is coming. The RR cycle. It has come to 400, then 300, 200. So I think the basic EGM would have given us more insight.
Yeah, that EGM is not there. So what I showed is a different EGM. I told you that is a dual chamber.
That this is a T-wave oversensing. Only this pattern will not give us an idea. Although some tram track, but there is a gradual increase in heart rate before the shocks were delivered. So I have 2-3 questions for you, Suchit. We have moved towards basically DF4 leads, but what is the downside of DF4 leads? As we are doing physiological casing, we are using devices. But what are other downsides of DF4 leads? One, and second, what are the benefits of integrated bipolar? Because now we are moving away from integrated bipolar. So these two
So DF4 lead actually the advantage, disadvantage is that what I have mentioned. If you have a problem in one component, you have to change the whole lead. Means if you have a problem in the pace sense component, you cannot change only the pace sense component, and you have to change the whole lead. Whenever you are changing the whole lead, the problem is that putting two leads we always avoid, because there can be fibrosis and adhesions in the SVC around that coil area, super SVC coil area. Another what you are telling is that in days of physiological pacing, where we want to put the sensing lead and our shock lead can be made as different, where we want to put that. So for example, you want to use the something called the hot CRT, where you want to use his lead for sensing the RV, and for defibrillation you want to put a lead which has which has coils and which is a defibrillating lead in the RV. So you cannot have the same lead doing both the work. There you need a DFT, you need a DF1 this thing, where you can split the pace sense lead, which can be his lead, and the defib lead can be different.
Correct, and there is also benefit with defibrillation thresholds. You can manage add on extra arrays when you have given a DF4 lead.
Yeah, correct. If you want to add extra arrays, there also you can, DF1 lead is very important. Yes, correct.
And what about integrated bipolar leads? Like, what are the benefits, and why was it used, and why we are going away from it? Maybe sensing problem is the main issues. And what are the benefits of integrated bipolar?
Integrated bipolar, usually the advantage maybe one is that sensing. If it is sensing over a wider antenna. But if you have a problem with for example, if you have a problem with the ring electrode in a coil, in a in a RV lead, you can put this thing into integrated bipolar mode. If you put in the integrated bipolar mode, you can bypass the coil, and still you can have a good sensing. Sometimes integrated bipolar can be used to change the vector in a CRT also. where you can this thing LV lead, and also you can use the RV coil also for that.
So
Any other thing?
Do we have any questions from Anunay, Sanjeev, Dr. Kathuria, anyone?
सर वो लास्ट केस फिर से डॉक्टर सुचित लास्ट वाला
Yeah, last वाला जाए.
लास्ट जो फिगर बनाया था आपने
ये
नेक्स्ट स्लाइड
कौन वाला?
नेक्स्ट this one
This one actually it is showing that where you have for example you have a lead breakage of the insulation, and you have this thing where you have the RV lead, which RV coil, the conductor connecting to the RV coil is exposed in the pocket. So you can think that I'll show you. You can think this is the conductor related to the RV coil, which is exposed in the pocket, and you have the can. Okay. So whenever you are sensing, you are having, whenever you are delivering a shock, you are having a short circuit from this to this. So whenever you are delivering a high voltage, what happens is that because of this small gap, what they tell that form a very plasma formation here, and this can injure the can integrity. So that is called as dielectric breakdown and plasma formation.
Great. So
I think, Dr. Suchit, in the case which you showed about the T-wave oversensing, there comes the issue of having a very good R wave in patients with an ICD.
Yeah,
that's
correct,
where, because that's what you said. If you have no space between the R and the T, this has to be replaced. That's why the importance of an R wave while putting an ICD goes much beyond a pacemaker, because anybody who has started implanting should understand where that problem will arise. So you must even if you have dynamic. Even if you have dynamic parameters, the decay, delay, everything, the R wave on baseline in an ICD really matters.
Correct, because if it is very small, you cannot do anything rather.
You will have no space
except
to work.
And another thing is that Dilip's question here is important, because sometimes when we change the vector of sensing, maybe integrated bipolar gives another option, where if you change the vector of sensing, sometimes the R wave may be different and bigger in that vector. So that is also sometimes helps, rarely in T-wave over sensing.
thank you so much. And now can we move on to the presentation by Dr.
Yeah. I'm share stop.
Is my screen visible?
Yes.
My presentation is
presentation mode.
It's not a presentation mode, I think.
can you see my presentation, Dilipda?
Yeah, it's good.
Okay. So first of all, I must congratulate Dilipda, because he's such a busy person clinically, and at the same time keeping the zeal for academics is a very I would say it's a very difficult job. And second, it is always a delight to listen to Suchit's presentation. I think in Eastern India there is nobody who will be better in electrophysiological understanding in anyone in Eastern India. Maybe it was a great talk. I'll just start with this famous diagram from Swerdlow's paper. So I think we have ample time. We can go slow, and at the same time, I wish any one of you want to pause me in between. Please unmute yourself and ask your questions, or you can text in the chat box. But somehow I cannot see the chat box. So how can I go to the chat box? Yeah, now I can see the chat box as well on my screen, so that I can look into the chat box as well. So I have to make it full screen, right? Is it full screen now?
Yes.
Dilip, okay, thank you.
Yes.
So because I saw in the audience, majority of us are actually non-EP person, I will just take a little time to elaborate on this. There are a few youngsters who are aspiring cardiologists, but has a good interest in devices. So for the interest of them, it is not for Sanjeev Katuria or Sanjeev Mukherjee, Suchit, or Anunay or Dilipda. This is just for the upcoming cardiologists. So when you have a ICD here, this is called CAN. And as you know, there are coils. Generally now we use a single coil leads. So you have a coil here. So what is called near field is the tip to ring electrogram. Why it is called near field? Because this is a very small bipole and it picks up a very sharp electrogram. It doesn't look like a ECG. It looks like a spike because it is a very small bipole inside the heart. It only picks up the local electrogram. In contrast, which is called far field, that means it is something like a unipolar electrogram. From the CAN to the coil, it looks towards the heart's electrogram as a whole, like a bird's eye view. So when you look at the far field electrogram, you look at something like a ECG. So this is called leadless ECG. This is available only in devices where you have the SVC coil. Otherwise, it gives erroneous interpretation. So in leadless ECG, if you have a SVC coil, it even gives you a contour of the P wave. So from the ECG or leadless ECG itself, you know that you have a PQRS, something mimicking a electrocardiogram ECG of single channel. So just to re-emphasize that we have a far field electrogram and a near field electrogram. Both of them are generally recorded whenever you have arrhythmic episodes. Even you don't have arrhythmic episode, when you are interrogating a device, you get these two channels. Why this is very, very important to understand this is, why we could have chosen any one. Why there are two electrograms? So first of all, this near field electrogram, because it is inside the heart, it gives you the exact picture what is going inside the heart. And there is less chances of noise because it is a true bipolar signal. In contrast, when you have a far field that is called CAN to coil electrogram, you see a ECG-like contour and there is a little more chance of external noise or electromagnetic interferences. But what you get it from the information here is, you see a rough ECG. So if a patient's ECG, let's say is like, let's say this electrogram, this is predominantly positive. If you suddenly see the change in this morphology of this electrogram, you are pretty sure the patient is having a ventricular tachycardia and not a SVT. So from this morphology of this electrogram itself, you can tell with a substantial confidence that the patient is possibly having arrhythmia, and you can discriminate between SVT and VT. Hence, this far field electrogram is called discriminator. So there is something called morphology match in ICD. So in morphology match, it compares with the sinus rhythm morphology. Let's say this is the morphology at implant. It keeps a template in the mind of the ICD brain, and it compares when there is any episode of arrhythmia. So this is called discriminator. So second important thing is, generally this near field and far field go hand in hand. If you look at this two electrogram, you know this and this are simultaneous. So if a patient has a VT, obviously it will be fast, but it will be reflected in both the channels. It cannot happen that you see VT in far field, but there is no VT in near field. And the same is vice versa. If you see there are multiple spikes in the near field, if it is a genuine VT, you also should have rapid spikes in the or rapid QRS complexes in the far field electrogram as well. If there is a disparity between the two, you know there is something wrong. What is wrong? You need possibly you need to interrogate the device. The second important thing is, which is called marker channel. So if there is a discrepancy between the two, what is reflected in the marker channel is generally by default is the near field signal. As I said, this is more purer. This is a little pure signal. So this is reflected in the marker channel, So this QRS complex reflects as VS. If there is, let's say, VF, some devices call it F, some devices call VF. So it depends on vendors and companies. So this electrogram is reflected as V-sense, not this one, generally not this far field one. So if someone has multiple noise in the far field one, but a clean near field, his marker channel will also be clean generally. So with this concept in mind or this picture in mind, let us go into a couple of case examples and we will come back to this diagram if needed. I deliberately was little slow in explaining. Ranada, tell me anything you are Ranada, you have any questions?
No.
Okay, I'll proceed. So coming to my first case, I just want to highlight the underlying etiology of this patient. He's a rheumatoid arthritis patient, 50-year-old lady, recurrent syncope, and one of the syncope documented at a very fast ventricular tachycardia. His EF was little low. So we were thinking what to do for the VT, and we did a cardiac PET CT and MR. Both of them were positive, and she received an AICD 3 years back. She was doing very well over last couple of years, and we were actually on tapering antiarrhythmics. Now, within the lockdown period, she came with 5 shocks within last 48 hours. And this is what we see, episode which has been designated as VF. Now, the first job as a EP or a cardiologist is, you need to decide for which the patient received a shock or multiple shocks, whether it was a true VF or VT or it was a false shock. Let us go into the electrogram and then we see how we have analyzed it. I think Dr. Sanjeev Mukherjee has discussed last week about SVT and VT discrimination. There can be some overlap, just bear with me, but I think it will be a useful one for those who have not attended the last week's cases. So what we see here, this one V-sense amplitude is the near field one. So which has been being picked up or recorded at the tip. You see this is a sharp spike. It can be biphasic, triphasic also. Which is being called as discrimination is the can to coil. So this morphology will be kept as a template. If it is in sinus rhythm, then it will be compared with the VT morphology. What you see marker channel is what is being reflected from the near field. This electrogram is reflected as V-sense. A very important thing, this is a St. Jude device. What is given here is 98, 98, 96. What does these numbers mean? This means now the device is looking at each electrogram or each QRS complex and he is trying to tell you how much does the morphology match with the existing or previous template. This tells you almost all the complexes has more than 90-95% match, which is suggestive of possibly, because these are sinus, these are single chamber ECG, you don't have atrial electrogram. But from here itself, you know, although this rate is little fast, you can see the RR intervals here. The rate is in the range of 100 to 150. There is little irregularity. So two possibilities are there. Either it is a sinus arrhythmia going on, or it can be a atrial fibrillation. We don't know because we don't have an atrial electrogram. But what we can confidently tell from the morphology match that this tracing shows the patient is not having a ventricular tachycardia. Now let us continue into the episode. You can see here 0 second, 1 second, 2 second, 3 second, 4 seconds. So as we go on, I'm skipping some of these 6 seconds. We have skipping some of the electrograms. Now what we see here during the continuation, see this beat, the morphology was a -1 in QRS. This is why I'm highlighting this one, because this is the discrimination channel or the far field channel, which is used for discrimination of VT versus SVT. And you also see the morphology match is 96-97%. But what suddenly happened in the 21st second here, you see the morphology of the QRS has completely changed. At the same time, the score, you see the matching of the QRS complex, it is showing 0. So you are very confident that the patient's rate, although it has become fast, but not very drastically fast. Let's say the rate was around 400 milliseconds, means around 150 rate. His heart rate was 150, which was possibly a sinus tachycardia or atrial fibrillation. Now the rate is somewhere around 200. But you know that this patient has developed a ventricular tachycardia. The QRS morphology, even if you don't look at the match, from the morphology itself, you see this was a completely negative and now it is looking like a RBBB. So 9 out of 10 times it will be a ventricular tachycardia unless proven otherwise. Very rarely it can be a aberrancy, rate related aberrancy, but just don't think about the rare situation. Let's talk about the common situation. So what has happened? The device has picked up as a VT, or when it got fast, it has diagnosed as VF. And in the VF zone, initially it has given a ATP during the charging of the device, and because it saw, we can also see that the morphology remains same, like the VT morphology here. It remains same even after the ATP. So I will call it the ATP has failed to terminate the ventricular tachycardia. It is not VF actually, because you can see it is a, I'll show you a VF EGM. So it is a clear monomorphic VT, although it is very fast. So it is in the VF zone of the ICD. So it is being called VF. A ATP has been given. It failed. The ATP has failed to terminate the tachycardia, and a shock is delivered. So now the most important thing is to see whether the shock was successful or not. If the initial 3-4 complexes show some artifact, which is called polarization artifact, and then you see that original QRS complex has come back. So you know the patient has recovered into the sinus rhythm. Although the match is little erroneous here, that happens immediately after reversion into sinus rhythm. Gradually that picks up. That morphology match, you see, it has gradually improved into the 90s. So the summary of this case till now is the patient who had a sinus rhythm initially, or possibly a controlled atrial fibrillation, got into a ventricular tachycardia, monomorphic VT. The VT was very fast, so it was in VF zone. She received a ATP, which was unsuccessful in treating the tachycardia, and hence she appropriately received a shock. And we see here is the sinus rhythm, although there is a little sinus tachycardia. So I'll stop here. If there is any question, I'll take it, then I'll move forward. I do not see anything in the chat box. Hope something was understandable in this case. I will move forward. So what are the criteria that you decide it is a SVT or VT? So one criteria is called onset, stability, morphology. These are the major 3 criteria. The fourth one is PR logic, the relation of P to R. In the Medtronic and most of the devices, dual chamber devices have the PR logic. But let us concentrate what is onset, what does it mean? So if there is a rapid onset of tachycardia, the ICD will consider it as a VT. Although it can be atrial tachycardia, atrial fibrillation, anything can start rapidly. But for the ICD, if it starts rapid suddenly, it generally thinks it is a VT. What does it for stability? So if there is a slow onset, the device will call it a SVT. It will consider the gradual onset tachycardia as a sinus tachycardia. Although in rare situations, you can have gradually increasing tachycardia or VT. So, but for the device, it is sinus tachycardia. Next is stability. Now, stability means it is the RR interval. If the RR interval is variable, it will call it SVT because it is thinking about atrial fibrillation. Now, again, you can have irregular VT in sarcoid, in TB, but generally, in a blanket statement for ICD, irregularity means atrial fibrillation, so it will call it as SVT. Third is morphology. If morphology match, let's say a score, every device has their own scores, so say 70%, let's say. If majority of the QRS complexes has a match more than 70%, the device will call it is a SVT. So it can be sinus tachycardia, it can be atrial tachycardia, it can be atrial fibrillation, whatever, but it is not VT. If the morphology score is less than 70%, it will call it as a VT. And depending on these 3 data from the device, it will finally conclude whether it is a VT or SVT. There is a one arm, if you have dual chamber pacemaker and your number of V is more than A, that means you have a VA dissociation. It is anyway VT for us and also for the ICD. Now, So what happened, this is one of the VT which I have shown. So it is in VT2 zone initially. What did it show? So it showed that more than 90% match was not there. So it indicated VT. It showed the RR interval was not very much variable. So it was not a atrial fibrillation. So possibly a VT. And the sudden onset. It was sudden onset, and the stability was also there. So it was not atrial fibrillation. Sudden onset means it was not a sinus tachycardia. So from these three features, it calls it a VT and then goes for the therapy. Now, the same patient, I don't remember why I have put this again. So just, I think for, let us see, I'm just going through. So this patient, as I can see again, so there is a very good match. The QRS morphology is like sinus. Suddenly here again, there is a change in the morphology and the rate has become fast. So this is also a VT for me. And again, a VT therapy is given, which is unsuccessful. Again, a VT therapy is given, which is unsuccessful. No, which is successful. Oh, that's why I have shown this. I forgot it. So in the last case, we saw that the first ATP was unsuccessful, and immediately it gave a therapy because it was in VF zone. The same tachycardia. You can see the morphology. It was the same tachycardia. Only difference was the last tachycardia was a faster one. This tachycardia was a little slower one. So it was not in the VF zone. The zone can be set by us. So it was not in the VF zone. It is a VT2 zone where we allowed multiple ATP. And you see the multiple ATP, the second ATP itself has terminated the tachycardia. How do I say that? You see the morphology. The VT morphology was here like RBBB, and this is her own sinus morphology. So what can we do for this patient? ATP is always better for relatively slower tachycardia. So possibly we can increase the VF zone and we make the device a little less aggressive. The last one was not a true VF and she received a shock only after one ATP. So possibly we can allow more 3 or 4 ATP. If it fails, then it can go into shock, which is a painful therapy. ATP is a painless therapy. Sometimes patient doesn't even perceive that they have a VT and it has been terminated by ATP. Now, just to complete the case, how do I do with this patient? So the question is, she had a cardiac inflammation to begin with when she had initial multiple monomorphic VTs 3 years back, and his PET was positive. She was on drugs for rheumatoid arthritis. Now we did a PET, which is negative. There is no cardiac uptake. Had there been a multiple cardiac uptake, I would have hiked the anti-rheumatoid arthritis therapy. So I possibly would have hiked the rheumatoid arthritis drugs to suppress maybe steroid or methotrexate or whatnot. So we can have increased those drugs. But here PET is negative. So you know, you don't have much of inflammation in the heart. It is about the scar, and you need to take care of the scar by antiarrhythmic drugs. I just increase the dose of amiodarone. The patient is doing well. If needed, we can give another antiarrhythmic drug like mexiletine or beta blockers, and this is the thing. And if it fails, we can go for ablation if there is a VT stop. He was in VT stop. 5 shocks within 48 hours is almost a VT stop, but you can manage some of the VT stop with medications. All of them do not need ablation. Now going to a second case. Dilip, can I go to the second case? We have another half an hour.
Yeah, please carry on.
Okay. So if there is
Dr.
any
Deva,
doubt, yeah, please.
Dr. Bera, I think also explain them a little bit, whoever is listening, about if you're telling about stability, onset, as well as the morphology.
Yes.
And how is it programmed? Is it all on, depending on prophylaxis which you're giving, primary, secondary?
Right.
You can keep it all on one of them, 2 of them.
Perfect.
So they explain that you'll have to know why so many therapies are available.
We'll go to that. We'll go to that one by one. So what Dr. Kathuria has asked is very, very pertinent question. I will not go into the detail. There are several papers just on this topic. What do you do for primary prevention? What do you do for secondary prevention? I'll just give you a bottom line. For primary prevention, generally you need to give the patient prevention of sudden cardiac death. You don't need to, the patient did not have any VT. So what you are going to stop? So you can just keep one zone, VT zone above 220 or 230. If the LV function is very poor, then you can keep the VF zone something like 200, because some of them even don't tolerate a VT of 200. If it is a secondary prevention, like this patient, it is a secondary prevention. You know the rate of the ventricular tachycardia. So set a ventricular tachycardia zone around 20 to 30 bits lower. Let's say if her ventricular tachycardia rate is around 200. So you start your VT therapy something around 170 to 180. And above that, let's say 200, 220 to 230, you keep the VF zone. So this is how you generally, but there is a almost we can talk 2 hours about primary prevention and secondary prevention. How do you program the ICDs? Now, if I go to the second case, it is a little different one. He's a very young gentleman, 26-year-old male, recurrent syncope. Fortunately, one of the episodes documented a VF in 12 lead is a VF, and the VF was because of short coupled PVC. So when you have a short coupled PVC, you need to think about channelopathies, Brugada syndrome. These are the things which can give rise to VF and short coupled PVC. Long QT syndrome can give rise to triggered PVC and VF. Echo was normal for this patient because his QT was normal. It was not even a short QT, not even a long QT. It was labeled as idiopathic VF, and the patient received an ICD for prevention of sudden cardiac death. Now, the patient comes with a shock. Again, our same question, that whether the shocks are appropriate or inappropriate. So, this is the electrogram of the same patient. Let me show you. This is called EGM1 or the near field EGM. This EGM2 is CAN to coil. That means the far field EGM. And this is the marker channel. So, I wish any one of you can volunteer what has happened here. We can see in the marker channel that there is very fast annotation of an arrhythmia. Now, from these 3 channels, this is again a single channel ICD. Can anyone, not our EP guys or not experts like Dilip Da, from our beginners, anyone would try to attempt? What is it? Our options are SVT, or true VT, or true VF, or a noise or artifact. So these are the general options. For all patients, we have these 3-4 options. There is no 10. Either is a SVT or a noise or a VT. Simply these 3 are the options. So anyone can chat in the chat box or unmute yourself.
Fog dependent VF?
Anunay told? Anunay? Who spoke?
Yes, Anunay sir. Fog dependent VF.
You're an expert, man. I told this is not for.
No sir, no. Not for not in deep.
I'll open this again for our beginners. So we have many residents here. I am deliberately doing this because we have ample time. Till 8:30 we have time. So I have only one more case. So Manish has called it VT, and anyone else from our beginners. I saw Ayan was there, Amit was there, many residents from this thing, Medica, Apollo was also there. Anyone? So again, I am not finding any volunteer. Anyone who would like to unmute and talk to this? I'll wait for 10 seconds more or 20 seconds more, because these are truly difficult job to decipher that whether there is a true VT or a true VF or noise. Okay, Jaya Pradap is there. He has called PVC induced VT. Jaya Pradap, you are also expert. So Jaya Pradap is one of a very, very keen technician from M, and he knows better electrograms than many of our physicians and St. Jude technicians. Okay, so I can see in the chat box almost all of us. Oyan has also called it is VT. So perfect. So this is ventricular tachycardia. So whether we call it VT or VF, I'll go into the more detail into the next EGM. But what we need to know, even from this small piece of information, that this is not noise. Why do we call not noise? Suchit has very nicely or very elegantly showed how noise look like. So they are very continuous signal, even the non-physiological rates, let's say 100 milliseconds, 80 milliseconds. There cannot be any VF even with that very short electrograms. So electrogram intervals. So 2-3 things here you need to look at it. Just look at this one. Now in Medtronic devices, you do not get like the scoring here. You get the scoring, but not in the screen itself. It comes as a summary. I'll discuss that as well. So what you see here, that, as I said, the near field electrogram looks like a spike, whereas the far field looks like a ECG. Now, if you look at the spike, just blind yourself and only look at the near field electrogram. If you look at this beat, there is hardly any difference from the previous beat. So if you look at the electrogram, it looks like just a premature atrial complex maybe. But if you look at the far field here, you know the QRS morphology is completely abnormal. So you know there is a very short coupled PVC here. And the same thing happened here. There is a normal QRS, and a pacing spike look like in it, not pacing spike, I was wrong. So I meant to say there is a PVC, very short coupled PVC, which has induced a VT. In fact, this patient has similar history, very short coupled PVC inducing VT. Now, if you look at the electrogram, both bipolar and unipolar, they go hand in hand. So generally, you are not thinking anything abnormal. It looks like the device is fine. Both of them are going hand in hand, and there is discrete electrogram, not like noise. So these are discrete electrogram, both in near field and far field. So most likely this is VT. Nobody can be 100% sure, but I can tell 99.9% sure this is VT. Now, if you look at each beat, especially in the far field, you see there is subtle changes in the each morphology. So we will call it a polymorphic VT. In presence of long QT, we could have called it torsades, but we know this patient is a normal QT. So we will call it a polymorphic VT, which continues here. Now it is very, very clear. Some might feel this one is noise, but this is what you see in polymorphic VT. If you look at this, only this electrogram, this is a usual recording from a defibrillator when you shock a patient in emergency for polymorphic VT. And you see what has happened here. There is a shock, appropriate shock I will call it, and then you see a normal QRS complex. So the normal QRS complex is a little bizarre looking here because of the polarization artifact, what you find after immediate shock in all the devices. So this is a polymorphic VT, which was induced by a short coupled PVC, which have been appropriately given a therapy, which is shock, because this is polymorphic VT. Your ATP is not going to help in this polymorphic VT. So you need a shock, and he has received a shock, and that's why possibly he is alive. So this is what a Medtronic summary shows you. So we can go into minor details, but just I'll tell you a couple of summaries. So initial diagnosis VF, duration of diagnosis is 11 seconds. He has received a 34 joule shock, and you see there is match score. There is no matching. There is 0% matching in almost all. I think generally they show a percentage. Somehow it has not shown any percentage here. And this is how they program the zones: VT zone, fast VT zone, and VF zone. This is a Medtronic device, and what we spoke about. So wavelet means morphology match. We have kept a 70% score here. It shows that when you did take the template how long back. Then the stability was off here, onset was off here. So stability, you need to keep the stability on if you are really thinking a patient has atrial fibrillation. Otherwise, you may actually keep it off. So this is how it looks like in Medtronic devices. I'll just take another 1 minute to describe this EGM. What these dots show? These dots are RR interval. So if you look at this all dots, this tells you the patient has a stable heart rate. What is the heart rate? Let's say this is 500, and let's presume all the dots are at 500. So that means his RR interval is around 500 milliseconds all over. That means he has a rate 500 milliseconds means 120 rate. So he has a rate of 120. That is the sinus tachycardia. And you see a jump here. Suddenly there is a jump, and all the electrograms are same here. That means you have a stable tachycardia cycle length. What is the tachycardia cycle length? You see here on this y-axis. So that is around 150, 160 milliseconds, which is in the VF zone. Okay. So it was a polymorphic VT, and then you receive a shock, and then you see the RR interval. The RR interval is again around 600 milliseconds. So that means he has a sinus tachycardia of around 100 milliseconds, 100 beats per minute. So this, even if I don't show you this, the electrogram, even from this diagram, you can tell that patient has a sudden tachycardia. It can be atrial tachycardia, it can be atrial fibrillation, it can be a VT. But from this stability, you can essentially rule out atrial fibrillation. What is left is a regular SVT, like AVNRT, AVRT, atrial tachycardia, or it is a VT. For VT or not, you need to look at the morphology and the other things which I have shown. So from this electrogram itself, you know this is not a sinus tachycardia. In sinus tachycardia, there will be gradual shortening of the RR interval and it will enter into a VT zone. Hope I was clear. So I will just show this same patient, another shock. There is nothing new on this. So coming to the third case, I have 4 cases. This is the third one. If time permits, I'll go to the fourth one. So she's a 50-year-old lady. She has a arrhythmogenic right ventricular dysplasia, and and she also had recurrent episodes of syncope. She had a monomorphic LBBB morphology VT, which we generally find in ARVC, and she received an AICD. And after 4 hours, she received a shock. And let us see, because within 4 hours she receives a shock. You have a narrowing of your differential diagnosis, and this is your electrogram what you find. So again, this is a Medtronic device. This is RV tip to ring, that is near field, what is at the tip of the right ventricular lead. Then you have RV can to coil, and then you have marker channels. So notice that in marker channel, there are very frequent V sense episodes or VF episodes whenever there is a this noise or this frequent RR intervals in the far field channels. When the far field is flat, the marker channel is not recording anything. So again, the same question: was it a normal ECG? Was it a SVT? Was it a VT? Was it a noise? Was it an appropriate shock or inappropriate shock? There is a shock delivered here. So was it an appropriate shock or an inappropriate shock? I will tell you, this is a little difficult one. Before you answer, look at the electrograms carefully, then drop your answer in the chat box. If we have a volunteer, he can unmute and tell me the possible answer. I don't want the diagnosis. We want the answer whether it is an appropriate shock or an inappropriate shock. In other words, it is a VT or VF, or no VT or no VF. So Manish has called it noise. Be careful, Manish may not be right every time. Till now he has been right every time. So Ayan has written inappropriate shock. Now I will ask him to rationalize why it is inappropriate shock. But then what is the diagnosis? But let me see if anyone tells this is an appropriate shock or not. If anyone said it is inappropriate, what was the evidence or glaring evidence that it is inappropriate? So I'm waiting for a few more responses in the chat box. I have got a few. Okay, so correct. So what Anunay has written here is the crux of this electrogram, and that tells you this patient doesn't have any arrhythmia at all. So as I said, you cannot have your near field which is clean QRS and you have a VT or VF in the far field, because both of them are essentially recording the same arrhythmia. How can you have a VF in the far field and clear regular complexes in the near field? So from the near field, you know the patient is clearly in the sinus rhythm. What you have here in that case, when you have a clear near field signal, is nothing but noise. Now you need to sort out from where the noise is coming. So the noise can come from couple of things. One is from the lead. If there is a lead fracture, it is unlikely in a 4-hour-old lead. Then a noise can come from the lead and the device junction where we screw. Generally, that is common because 3-4 hours is a time, perioperative period is a time when patients with loose set screw have shock, and there can be electromagnetic interferences from outside, like Suchit has shown, swimming pool, then you have a micro oven, you have some extra device in the room, switchboard, so they also can cause noise. But generally, the noises are seen both the fields, not only in the far field. Here, the near field is by and large clean, but only in the far field noise was there. There are multiple things on this electrogram. I will not go into why the far field had only noise, not the near field. Just for the time being, remember the far field comes from CAN2 coil, and that shocking channel or the shocking lead was loose, and she received a shock. I just told you the diagnosis. She has a loose set screw. Now, what is on this busy slide? Just look at here. As compared or in contrast to the previous case, you see during the VT, there is bizarre recording of the RR interval. So it is almost haywire. The RR interval is nowhere. If I ask you what is the RR interval, you cannot even say it is 900 or 150. So it is going nowhere. This is one of the evidence the patient is not having any arrhythmia. Most likely it is having noise. His RV shocking coil impedance was fluctuating, although it was in normal range, but there was a drastic fluctuation within 3-4 hours, which gave us the clue that there is some problem with the shocking port. And it was found that there was a loose set screw, which was reopened and re-explored and fix it up. I'll stop my presentation here. I have one more case. If time permits or Dilip the permits, we'll go to that one. Otherwise, we'll stop here.
Yeah. Carry on, quick case. Yeah.
Okay, Dada. So I have only one more case. If there are any questions, so then they can text on the chat box. So, oh, sorry. So let me look at the chat box once. Where is the chat box? Any questions, Dilipda? So, Debabrata Bhattacharya, what do you think it is VT zone? Do you want to keep it little longer as you always keep VT slightly lower side? And okay, I'll go to that. In the first case, why SVT went into VT? Okay. So these questions we'll discuss later. So let us finish one of the last case, I would say. And then we can take it from there. I have 10 minutes left. So I'll make it little quick, but not rush through. So this patient is a restrictive cardiomyopathy patient, biopsy proven cardiac TB, severe LV dysfunction, and she had a AICD around 5 years back. Now she came with one ICD shock. Now again, the question is same, whether the shock was appropriate or inappropriate. Because if it is an appropriate shock, you need to treat the VT. If it is inappropriate shock, you need to fix up why it was inappropriate. Like last case, it was inappropriate shock. We had to fix up. It was a loose set screw. It was a dual chamber, dual coil, St. Jude ICD. And unfortunately, she was allergic to amiodarone. So if it is a true VT, then we don't have the choice for amiodarone. And this is the VT episode which has been recorded. Again, a very busy slide. Let me go by one. So first of all, this is the atrial EGM, which shows discrete atrial electrogram. So from this, at least we can tell that this is not an atrial fibrillation. It can be anything else other than atrial fibrillation. Coming to the leadless ECG. If you look at the leadless ECG, this is only valid for dual coil ICDs, and it was a dual coil ICD. So leadless ECG can give you PQRS picture, although it is little bizarre here. Now this is called near field. What you see near field, these are the QRS complexes. And the same thing far field. These are the QRS complexes, and discrimination. This will determine the morphology match or not. As you see here, the morphology match is 94-95%. So from this slide, if we try to decipher it is a VT and why it diagnosed VT, we have more slides also. But from here, what is clear, if you look the number of A and number of V, you see the number of A is grossly more than number of V. So it is unlikely that this is VT unless there is a dual tachycardia. Means the patient is having a atrial flutter in atrium and VT in the ventricle. That sometimes happen in rare situations, but otherwise A is more than V. Okay. Now, what does the morphology tell you? You see, wherever the morphology score has been given, it is all more than 90-95%. There is little irregularity in the RR interval. So, if we logically think the device having a irregular RR interval, should it call it a atrial fibrillation or SVT? If the device was properly working, with this percentage of score, the device should have called it a SVT, because all scores are more than 90%. Then why did this patient called it as VT? Now let us go into the picture of the patient. This is just a slower version to tell you this in 50 speed. The number of A is much more than number of V. Now, what has happened? That number of A more than number of V continues, and there is a diagnosis of VT. I will come why the diagnosis of VT came into picture, because clearly it should have called atrial flutter or SVT. Now it has given a ATP, which is called stim. So the ATP has given. Now you look at the QRS morphology that has changed. You look at the morphology before here. So what is the morphology? This is the main morphology, discrimination. You need to look at it. This is the main channel which will tell you that the device is going to call it VT or SVT. Now, when you look at the morphology, it has changed. So as the leadless ECG. This leadless ECG and both of the far field has changed. So most likely, we are not 100% sure, but 90% this patient developed a true ventricular tachycardia after an ATP, and then it goes faster and enters a VF zone. That's why it is called VF, and the VF triggers off. There is a triggering of VF and receives a shock. Why did not give a ATP during charging? Because the device is intelligent. It saw in the last time when it delivered the ATP, the interpretation was it made the VT faster. So this time when the VF was detected, no shock during charging, and directly a shock has been given, and you see there is no arrhythmia here. Even the atrial tachycardia has cardioverted, so as the ventricular tachycardia. So if you ask me, I will call it, it was to begin with, it was an inappropriate therapy. The ATP was inappropriate, but the VT was appropriate for a fast ventricular tachycardia. To summary, to start with, it is a paroxysmal atrial flutter. It was not very fast either. There was a good morphology match, but why then there was a therapy? So for this, you need to look into detail of the printouts. So there are again a busy slide. Don't go into all of them. Just see what is written ATP therapy. The result is acceleration to VF. And then there is a defibrillation, and then the result is sinus rhythm. Now, why did this call it VT? Although even for a MBBS student, this is a SVT to begin with, because A is more than V. So logically, it is atrial flutter with conduction. So then why, how come this VT diagnosis came? And it tells you surprisingly exactly reverse. That is V more than A. My God, how can this do a V more than A, where we can, it is glaring to us the number of atrial signal is more than V. Then when we looked into the, and as I said, whenever there is V more than A, it will see nothing. This morphology, stability, nothing is considered. It straight away goes for therapy. So this is something you need to take care for. Whenever you have a V more than A, to be very sure, you have to determine that it was a true VT or not. In this case, now if you, the same EGM, I have just zoomed it to tell you, you look at the atrial electrogram and you look at the marker channel. So this A goes to this spike in the marker channel. This A, which is a red star, doesn't go into the marker channel. Why? The next A goes into the marker channel as a spike. Then this A doesn't reflect into the marker channel. The next A, although the bar is not seen, it is shown 92%, so it is reflected in the marker channel. But this A again is possibly not reflected in the, so whenever there is a star I have given, there is no reflection of the A into the marker channel. So generally we call it atrial undersensing. But the A waves are quite large. Why there will be atrial undersensing? That takes us to another set of data which is called post-ventricular atrial banking. This post-ventricular atrial blanking is something set in the atrial channel to avoid far-field electrogram of QRS. So that this far-field R wave is not reflected into the atrial channel, this atrial channel. Somehow his P-wave was very long. It was set 200. Generally for ICD and CRTDs, the P-wave is generally short, 60 to 70 milliseconds. So that at quick successions, if the QRS complexes come, it is usually picked up. I don't know who has programmed this. Someone has programmed this to 200 milliseconds, this thick bar. And many of the atrial electrograms were undersensed. Hence, as the A was undersensed, falsely the V became more than A. So the number of V, which was correctly calculated, but the number of A were incorrectly calculated very less. So the arm of V more than A was activated and she received a therapy for V more than A, which was an inappropriate one. We just reduced the P-wave. There are multiple ways to do it. I'm just not going into them. So we just made the P-wave less and the patient is doing well. So I stop here. I understand this might be little difficult for some of our aspiring cardiologists, but ICD itself is a little tricky topic. So I tried to make it little simple. It was great that Suchita spoke a lot about the theoretical part so that it was becoming easier for me to discuss. Dilip, that's all. Rana and Dilip, it's all over to you.
Yes, Rana, your comment.
No. Definitely, it was an excellent talk, and he started from the basics of the ICD and covered most of the common issues what we face after ICD implantations. And whatever the case he has shown, I think it was a very learning case for all of us. So definitely, it was very helpful for all of us. So thank you, Devu, for so nice presentations. Thank you, many thanks.
I have one or two remarks. Like,
yes, please.
First case, you showed that patient within 4 hours, patient received a shock, and it was a loose screw.
Yes.
The moment you program this, integrate these patients, you will find a impedance, maybe shock impedance, shocking pulse. Much wearing around, and that is when look into there is a screw is not properly it was not properly given.
Yes.
And it is air in pocket. Less than 4 hours, if you get to see this kind of
great.
And
right.
Not getting in a proper sensing and in a shock. How big the problem is air in pocket nowadays, because we are moving towards mostly bipolar, sensing. And what is the status? And air in pocket, have you seen any case or not till now? I don't think the problem.
I haven't seen any. You have much vast experience than me. Possibly you or Suchita or another will be able to. I really don't know how air in pocket presents.
Yeah, but is it in differential diagnosis? I think these two differential diagnoses will come.
Absolutely.
And this, we have already exceeded, but last comment from you and Suchit also. How in your experience, those patients who have VTS trauma after an ICD, how many of your cases till now have gone for a stellate ganglion blockade, and what is the result? Like we get to, in theory, in practice also from other centers, we get a lot of patients, but in our center, we have not done it. And what is the experience at RTSS and Apollo? I wanted to know.
So Suchita, please, then I'll put my remarks. Suchita has left, I think. So
mute was there.
Okay, sorry.
Okay. So basically, say Apollo, I have not seen or done those sort of cases where stellate ganglion blockade was done. But from my past experience where I was trained or whatever I have seen, we have, whenever I was trained, I remember around 2-3 cases where stellate ganglion blockade was done. Why? Because mostly these are polymorphic VT. Sometimes it was channelopathy related VT post ICD. There one was like that. Another case was a polymorphic VT, almost like a short coupled torsade, but it was very difficult to control, and there I think it was done. So the result is that it's a good, where it works, it is good. It needs a bilateral stellate ganglion blockade. Initially, you have to do by a bupivacaine injection to see that it works or not. If it works, then you have to go for a surgical thing. But Debabrata, I think, will have a better experience because the center in Bombay, there is a very good cardiac thoracic surgeon who is specialist in that.
I think Dilip specifically asked for local stellate ganglion blockage because for us in Calcutta, that is more relevant, accessible, because unfortunately in Calcutta, I don't know any surgeon who does a open surgical stellate ganglionectomy, bilateral sympatherectomy.
I was just, discussing this with, one of the EP guys who have done, a lot of cases. And
Right.
it's become a kind of protocol. If the patient has come with an ICD and a VT storm, we first go for a ganglion blockade, and we get very good results.
Okay.
And we can avoid, taking this patient for catheter ablation.
Absolutely. The only flip side is many of the patients which we face are ischemic cardiomyopathy, and some of them, let's say, atrial fibrillation. So someone is on dual antiplatelet or someone has anticoagulation, anesthetists are little hesitant. I don't know whether you yourself do or anesthetist do or critical care person do. So they're little hesitant. I myself do not do, I'm not very confident in doing stellate ganglion blockage. So,
That's by cardiovascular surgeons. And I came to know that it's not a big surgery. It's a small surgery. It is, but just I was wondering why in Eastern India we have not done. And
no, but you are you are talking about surgical sympatherectomy, or you are talking about local injection?
Local, I don't have any idea, but I was just discussing about this surgical therapy, which is not very
done in your center, right?
No, we were about to do a case, and
I know. So unfortunately, I haven't encountered any patient of such a VT storm that I had to consider. Only 2 patients I had ischemic cardiomyopathy whom I had to consider either a ablation or a stellate ganglionectomy. One patient I did ablation and it was good. The patient is still doing well. The other patient I had hindrance for ablation because it was some scheme patient, some of the hardware are not available. So I thought of doing a stellate ganglion blockage, but our surgeons were not very ready. At least.
Take help of your surgeons, I think, and convince them that it's not a very big surgery.
Yes. I think there is not a very steep learning curve. It is a good learning curve. Anuna is also here. We have worked in Bombay Center. They have very vast experience in bilateral sympathetic ganglion means sympatherectomy. Not I would say blockage. Blockage usually we mean by local anesthesia. So sympatherectomy is pretty useful. In fact, in Bombay Center, they hardly do any ablation. Okay. Although that is not the norm, what I am trying to say that sometimes it is, they are complementary to each other. So ablation and stellate ganglion blockage, they are complementary to each other. Both of them have own good and bad sides. So possibly we need to have both in hand.
Picked up in Eastern India as well. That's what
yes, we have to pick it up.
So thank you so much, Debu and Suchit and Rana and everyone. Suchit, Sanjeev, Anunay, and everyone there. And we'll meet again. We have 2-3 webinars left more. And thank you so much. Thank you.
Thank you very much. Thank you.
Thank you, Dr. Dilip. It's really great initiative.
Thank you, Debabrata, very much.
Thank you.